Right, hi, I'm Lena. I'm supposed to be zooming a tutorial for people to watch, but apparently there's just me. Hopefully this is recorded so that lots of us can watch it later. I don't know, the slides will be up as well. We'll just go through these slides and have a chat about them. So first, a couple of things to talk about. How do we study for progress tests? How do you guys do it? Have a think about that. Just a discussion point for you. So this is how I used to study for my progress tests. At the end of year 3, I went through all of my past notes and I wrote down all the clinically relevant information, which was really helpful. I read through the Oxford Clinical Handbook that I had. I tried really hard to read a chapter of it every night, or read an important part of it, but I lost the book, so I can't do that anymore. I also tried my best to read through the clinical scenarios online. If I didn't understand something, I tried to develop a better understanding of that area, and of course I practiced my MCQ taking on PassMed. Nowadays I just use PassMed, and that's bad. I should do all the other things as well. I do enjoy progress tests. I think they're a fun way of testing knowledge out. They're quite stressful, but it's nice that they're not graded, A, B, C, D. It's nice that it's pass. Sometimes if you're lucky, or if you're very, very smart, you'll get excellence or distinction or whatever it is. If you're not so lucky, you might get borderline or you might fail. But the vast majority of us will just get a pass, which is excellent, and you want to be in that vast majority, really. Yes, so let's start. We're going to do digestive questions and GU questions today. So first up, 33-year-old New Zealand European woman presents to a GP with fatigue, 5 kilograms of unintentional weight loss and acid reflux over the past 6 months. Recently she's begun to feel full after small meals, and on examination you feel an abdominal mass. So what do we think would be our next step in management? Prescribe pantoprazole, organise an urgent gastroscopy, refer to surgeons for fund application, or organise a stool sample for H. pylori. Pause the video. I don't know. Pause the video and think of what you would do in this case, because the answer is probably organise an urgent gastroscopy. This patient's probably got gastric cancer. We know this because of the fatigue, unintentional weight loss, and the feeling full after small meals and feeling an abdominal mass. Stuff like weight loss, fatigue, that stuff is kind of like an alarm symptom for cancer. Acid reflux, again, probably there's something blocking her stomach, meaning that she's getting heartburn or feeling like she's got some sort of reflux. Feeling full after small meals, again, something's filling up her tummy that isn't supposed to be there, and it's cancer. So gastric cancer is a poor prognosis cancer. Symptoms are late, so she's probably not going to be doing so well with the gastric cancer. Things that increase your risk of gastric cancer are the regular stuff: smoking, obesity, viral infections, some viral infections. H. pylori is the classic infection that we like to think of. Not viral, asbestos exposure as well. A couple of early symptoms, I guess, would be the indigestion and the heartburn, and then later symptoms: weight loss, feeling full after small meals, abdominal mass, and also things like melena. If you've got the gastric cancer is bleeding, then that blood is, as it progresses through your digestive system, it goes black and tarry, and that's melena. Things the doctor might do for a patient who's might have gastric cancer, or they might do a full blood count to see if they've got any anemia because of occult bleeding. They might do an endoscopy, as is in this case. Could do a CT, a barium swallow, and of course you want to do, with your endoscopy, you want to grab a chunk of that cancer to have a look under the microscope at the histology. CT we would use, in reality we would do gastroscopy, CT and histology, and the CT and histology is varigrading and staging. Treatment, the regular, you could do some chemo, radiotherapy, chop it out. But poor outcomes. Overall, the 5-year survival rate is 31% apparently, which is a bit sad. And go through the other answers rather. So pantoprazole, that's a protein pump inhibitor that treats reflux. Fundoplication is surgical treatment for GORD, esophageal reflux disease. And a stool sample for H. pylori. That H. pylori does cause reflux and stomach pain, but she's got all those symptoms of cancer. She's got those alarm bell symptoms. Cool, alright. Next question. 7-year-old New Zealand European boy, ill-defined abdominal pain, diarrhea almost daily for 3 months, seen by his GP. He slipped from the 25th percentile for weight 12 months ago to the 2nd percentile. On examination, he has a bloated, tender stomach. What's the most probable diagnosis? A. Celiac, B. Functional abdominal pain, C. Anxiety, or D. Urinary tract infection. So again, pause it here. What do you guys think it is? Well, the answer is celiac. So for kids who have celiac, it can be as soon as the kid starts, well, as soon as the baby starts eating celiac, around 6 months or 7 months, they start getting symptoms, very irritable, bloated, diarrhea. But for some other kids, it comes on a little bit later, and they've always had problems with it, but the problems just get worse and worse as they get older. So common symptoms for celiac in kids are diarrhea, decreased appetite, stomach ache, bloating, poor growth, weight loss. Many kids are diagnosed with it between the ages of 6 months and 2 years old, as I was saying before. There are other symptoms of celiac, including a really horrible rash, and we all hopefully remember that celiac is implicated with a gene called the gene HLA-DQ, and we can test for celiac with anti-TTG and anti-EMA antibodies, but mostly we do an endoscopy for biopsy, and we biopsy the duodenum. And to see whether or not that biopsy shows celiac, there's the MASH stages, and they're on the slides. They're quite complicated, but essentially, like keywords that you'd be thinking of are villus atrophy, crypt hypertrophy, hypoplasia of intestinal architecture. So other possible diagnoses we could have had for this are things like inflammatory bowel disease, Crohn's, ulcerative colitis, but these seem to come on a little bit later in life, maybe in your teens or 20s. So functional abdominal pain, it is what it sounds like. You've got a sore tummy, but no real cause for it, no real problems, like no real reason for the tummy pain. That's why it's functional. You wouldn't have that like diarrhea, that really terrible diarrhea, and the weight loss. And that's similar to anxiety. Some kids get really bad sore tummies with anxiety. And a urinary tract infection would most probably have a shorter time course. Next question. 35-year-old man presents to his GP with alternating loose stools and constipation and abdominal pain for the past 4 months. He has not lost any weight, but he has recently found blood in his stools, and after having a colonoscopy, he is diagnosed with ulcerative colitis. What would be the initial treatment for this patient? Adalimumab, FODMAPs diet, prednisone, or sulfasalazine? Pause now. Have a think. What do you think it is? The answer is sulfasalazine, or however you say it. So that's a 5-ASA. ASA is some acid. 5 ASAs, that's all I can remember. And this is used first up for patients who have something like ulcerative colitis or Crohn's disease. It reduces the symptoms. It's quite helpful. All the other ones are also things that we could do for this patient. So adalimumab is also called Humira, and it is a monoclonal antibody that is used for patients who have very bad ulcerative colitis. Prednisone is also used for flare-ups. Prednisone is a steroid, as we all know. FODMAPs is not technically a treatment. Some people do like to go through the FODMAPs. So FODMAPs is a whole lot of sugars that some people think cause sore tummies. People who have irritable bowel disease or irritable bowel syndrome often go through the FODMAPs diet, and essentially you cut everything out. FODMAP stands for the different sugars. Let me bring it up. What the food are, what you're not allowed. Fructose, lactose, fructans, galactans, and polyols. Essentially anything delicious. You're not allowed on the FODMAPs diet, and you add them in slowly to see add them back in slowly to see if your gut doesn't like those foods that contain FODMAPs. And here we go, FODMAPs. Fermentable oligosaccharide, disaccharide, monosaccharide, and polyols. Yeah, stuff that's beautiful for you. Tastes beautiful. And then you add those back into your diet to see if you can handle it, if you can stomach it or not. And if you can, then you can keep it, and if you can't, then obviously that's something you shouldn't have. And some people find that following a FODMAPs diet is really helpful for controlling their symptoms. Right. Next question. 73-year-old New Zealand European woman whose BMI of 35 attends her GP appointment complaining of heartburn. After meals, she's tried eating smaller meals and she's had no other alarming symptoms. What is the first-line treatment for this patient's heartburn? Omeprazole, ranitidine, Gaviscon, or rest and reassure? Yes, pause the video. Let's have a think about what we would want to do. Right. The first line treatment is probably omeprazole. So this patient has heartburn because she is obese. She has a BMI of 35. She has no other alarming symptoms, which means we don't have to go straight into a gastroscopy or think she's got something bad. First line treatment would be omeprazole, which is a protein pump inhibitor. It is the most effective. You take it 30 minutes before breakfast, and it pretty much helps with the entire day's worth of acid reflux. For patients who have quite bad acid reflux, you take it twice a day. Ranitidine is a H receptor antagonist, H2 receptor antagonist. It is much less commonly used nowadays because protein pump inhibitors are so much more useful. Gaviscon is an antacid, or rest and reassure. We can give a medication that will help with that, but we would want the patient to lose weight and stop drinking alcohol and stop smoking and all that good wholesome stuff that improves our overall health. A 22-year-old New Zealand Māori man with a long-standing sports injury presents to hospital with a bleeding peptic ulcer. He admits to taking 6 200mg Nurofen tablets a day for 3 months. So what is not a common side effect of non-steroidal anti-inflammatory drugs? Heartburn, dizziness and headache, muscle weakness, or tinnitus? Pause, have a think about it. The answer is muscle weakness. So heartburn, dizziness, headache, tinnitus, stomach ulcers, peptic ulcers, those are all side effects of non-steroidal anti-inflammatory drugs, and we know this because they are COX-1, and Nurofen especially is a COX-1 and 2 inhibitor, which means that it stops the normal production of the helpful layer of mucus layer in your stomach. So that's why all the gastric stuff comes along, and NSAIDs just aren't all the gastric stuff like reflux, heartburn. And it's also not great for your kidneys, and it's not good for your central nervous system as well, which is why you get dizziness, headache, and sometimes tinnitus too. So, next question. 33-year-old New Zealand European woman presents to her GP with pain before meals and acid reflux over the past 6 months, and you organise a stool sample which is positive for H. pylori. What is the treatment for this infection? Clarithromycin, amoxicillin, and omeprazole, amoxicillin, metronidazole, and pantoprazole, metronidazole, pantoprazole, and just amoxicillin. And the answer is A, clarithromycin, amoxicillin, and omeprazole. That is called our triple therapy, eradication therapy. Clarithromycin plus an amoxicillin or metronidazole, not amoxicillin and metronidazole, and a protein pump inhibitor. That's our triple therapy. Okay, cool. A 72-year-old Māori man presents with difficulty swallowing and often vomits undigested food. It's been getting worse for the past 3 months. He's lost 6 kilograms. He undergoes a barium swallow, which shows a characteristic bird beak appearance. So what is the cause of his dysphagia? Esophageal spasm, benign esophageal stricture, achalasia, or eosinophilic esophagitis? Pause here, have a think about it. What's the answer? Achalasia, and there's a picture of the bird's beak deformity right there. So there are lots of different esophageal pathologies, and it can either be in the esophagus itself, or it could be in the oropharynx. There are specific phrases that I like to think of for different dysphasias that remind me of that, like a buzzword, and for achalasia it's bird beak appearance. Esophageal spasm, it's really rare actually. A type of esophageal spasm is the nutcracker esophagus, and it's a lack of relaxation of the smooth muscles in the esophagus. Benign esophageal stricture is after heartburn or gastritis, some sort of inflammatory process where there is a increase of hypertrophy of the cells around the bottom sphincter, and it causes stricturing, and so it's harder to get food into the stomach through the lower sphincter. And achalasia itself, so achalasia is caused by a lack of relaxation of that lower esophageal sphincter, and when it's really bad, it causes all that huge dilatation at the top of the esophagus, which we can see in that bird's beak deformity picture. And eosinophilic esophagitis is, we would see that after asthma or allergy, that would be in the question. Right, you are on your surgical placement when a 40-year-old New Zealand European woman presents to emergency department with sudden onset abdo pain in her epigastric region. She finds the pain severe and she has been vomiting. She has no relevant medical history. Blood tests are ordered and the results show serum lipase of over 1,000. So what is the most probable diagnosis? Could it be acute appendicitis, acute pancreatitis, acute gastritis, or cholecystitis? Have a think about it. The answer is pancreatitis. And why is that? It was because I talked about serum lipase, that's why. That's the next question. Well, let's have a discussion about acute pancreatitis. Everyone remembers I get smashed. So it's a mnemonic for the causes of pancreatitis. So idiopathic, heaps of pancreatitis. Actually, we don't know why people get pancreatitis sometimes. They just do. Gallstones can block the pancreatic duct and you get pancreatitis. Alcohol abuse, trauma to the pancreas, too many steroids, mumps and other infections. M can also stand for malignancy, so pancreatic cancer. Autoimmune diseases, scorpion stings and spider bites. Very, very, very uncommon cause of pancreatitis. Hyperlipidemia, hypercalcemia, hyperparathyroidism, aka all those metabolic disorders that cause too much of something. And ERCP, so ERCP is a way of grabbing, is a way that general surgeons and gastroenterologists like to remove gallstones, and it can cause pancreatitis, kind of like the trauma thing, or iatrogenic causes of pancreatitis. And there are some drugs such as furosemide is a good example, azathioprine, some thiazides. Those can cause pancreatitis as well. But the I, G, E, and T, those are the four most common causes of pancreatitis: idiopathic, gallstones, alcohol, and trauma. Appendicitis, we would see that in the right iliac fossa, so that's where she would be saying her pain is. Gastritis is in the same area as pancreatitis, but serum lipase levels were talked about, so it's not going to be probably not going to be gastritis. Cholecystitis is right upper quadrant pain, classically. Next question. 67-year-old Cook Island Māori man presents to his GP after his wife commented he had gone yellow. He'd recently been feeling fatigued and suffers from bouts of abdominal pain, especially after eating. You speak to him and he tells you his stool is pale and his urine is dark. What is the most probable diagnosis? Cholangitis, cholecystitis, cholangiocarcinoma, or primary biliary sclerosis? Pause. Have a think about it. Which one do you think it is? Probably cholecystitis. So, there are probably cholecystitis. This question was a bit hard to write up. Hopefully we all know the different choles. So let's start with cholestasis. So that's slowed flow of bile. Cholelithiasis are gallstones in the gallbladder. Cholecystitis is inflammation of the gallbladder itself. Choledocholithiasis is gallstones in the duct. Cholangitis is inflammation of the ducts. So he's got a bit of jaundice, he's been feeling fatigued, suffers from abdominal pain, especially after eating, and his stool is pale and his urine is dark. It sounds like he's got some sort of gallbladder problem. Could be cholangitis, could probably be choledocholithiasis or cholelithiasis, but it's not cholangiocarcinoma because that would have a long-term history because it's cancer of the bile ducts and it's very uncommon. And primary biliary sclerosis is, it is an autoimmune disease. Quite uncommon. You would see it more with other autoimmune diseases like ulcerative colitis. Cool, and the next question is the last gastric question. 45-year-old New Zealand European man presents to the general medical clinic. He has been feeling run down for some time. He feels nauseated and sometimes vomits, and he drinks 50 units of alcohol a week. What could his diagnosis be? Well, let's have a look at his liver function test. His GGT is high, his bilirubin is high, his ALP is high, very high, Oh no, not too high actually, I take that back. His ARP is high, his ALT is high, and his AST is higher than his ALT, and his albumin is low. So could it be alcoholic hepatitis, hepatitis B, hepatitis C, or cholelithiasis? Have a think about it. What's the answer? It's probably alcoholic hepatitis. The way that I try and think about alcoholic hepatitis is your AST is normally higher than your ALT, especially if you've had a big binge drink before you come to the hospital. That's because if we think about, well, let's go through the liver function test. So ALT and AST are markers of hepatic inflammation. And I like to think of the L and the S. L stands for long and S stands for short. So ALT is a marker of long-standing liver inflammation, and AST is a marker for short-term liver inflammation. ARP, GGT, and bilirubin are all measures of, I like to think of like inflammation of the bile duct or blockage of the bile duct, especially in the case of bilirubin. Albumin is a measure of how well the liver is synthesizing proteins. Low albumin means the liver is not doing a great job, and that's the same with the prothrombin ratio, prothrombin time. So hepatitis B and C, you would see increased hepatic inflammatory markers, but it's not in the history that he's been overseas or that he's had contact with patients with people who might have hepatitis B or C. He drinks a lot of alcohol, which is kind of the key word there. Cholelithiasis, he wouldn't have the really, really high ALT and AST. Cool. So that's the end of our Dig questions. I hope that's all making sense for you. If it's not making sense for you, please email me. My email is ltuc336@aucklanduni.ac.nz. Alright, next question. A 65-year-old Dutch male retired plumber has a history of a slow stream of urine and needing to get up to a void once or twice in the night. He's been referred to the urology outpatient clinic after a blood test showed an elevated PSA. What is the most probable cause for symptoms? So prostate cancer, prostatitis, trauma to the prostate, or benign prostatic hypertrophy? What do we think it is? Well, it's probably, I feel like it's changed. Yes, the question was changed. That's funny. Anyway, the answer is BPH. All of the answers here, they can all cause a high prostate-specific antigen. This question is trying to show us that PSA is often touted as something we use for cancer. And sure, if the PSA is like over 20, then that might mean that the patient's got, probably means the patient's got prostatic cancer. But PSA is specific to the prostate, it's not specific to cancer. So all of these things below, including being old. Being old is a great reason to have a mildly elevated PSA. Old men get it all the time. Long history, 1 year history. Does it say 1 year in this question? It just says history. Anyway, 1 year history means that it's probably a long-term problem. So prostatic cancer or benign prostatic hypertrophy. Oh wow, this question completely changed between the things. Sorry, friends. Even recent urinary catheterization is a cause of elevated PSA. So is recent, oh no, I just said that. Your urinary catheterization, trauma, age, recent ejaculation, those all cause high PSA. Prostatitis would have short-term elevated PSA, short-term history. You'd be feeling unwell in the way that inflammation often does. Trauma to the prostate, you'd be like, well, it was trauma. That's why. Recent urinary catheterization, they would say that they were catheterized recently. It'll be in the history. So that leaves us prostate cancer or BPH, and BPH is far more common than prostate cancer. Prostate cancer is a very common disorder among men, especially as you get older. The older you are, the more likely you are to have prostate cancer, but it's quite treatable, and most people die with prostate cancer, they don't die of it. So thinking BPH is completely reasonable, and that's what I would have put. Right, next question. 18-year-old European woman presents to the student health clinic with burning discomfort when she passes urine. She has recently started uni and has a new boyfriend. What medication do you prescribe this patient? Trimethoprim, nitrofurantoin, augmentin, or metronidazole? What do you guys think? It's trimethoprim. So first line, trimethoprim. If trimethoprim doesn't work, probably use nitrofurantoin. Nitrofurantoin doesn't work, then you can use augmentin. There are different things that cause urinary tract infections. In a young woman like this woman, it's probably either E. coli or Staph saprophyticus. Trimethoprim is what we use for E. coli, and we like trimethoprim because you only have to take it once a day, hopefully in the evening, so that there's high concentrations of the trimethoprim. Nitrofurantoin is what we use afterwards. It's less helpful because you have to take 4 a day. Yeah, that's right, which is bad. And augmentin's real helpful, but it's quite a strong antibiotic, and we don't want to use it too much because of antibiotic resistance, and we wouldn't use metronidazole. And if it did happen to be Staph saprophyticus, then we still use nitrofurantoin. So trimethoprim and nitrofurantoin are very helpful for our community-acquired UTIs. In older patients who get UTIs, it could be E. coli, it could also be a yeast or a candida infection causing a UTI. Right, next question. A 21-year-old New Zealand European woman is referred to a gynecologist as she has not had her period for the past 6 months. Also troubled by increasing hair growth affecting her face. What would be the first line treatment for this patient of the ones below? So urofoliotropin, metformin, isotretinoin, or combined oral contraceptive pill. Pause, what do you guys think? Yes, the answer is the combined oral contraceptive pill. So the issue with this woman is she has polycystic ovarian syndrome. She has increased testosterone levels in her body, which is giving her increased hair growth and reducing her normal periods. And we sort of dampen down that increased testosterone by giving estrogen and progesterone. So metformin is a drug for diabetes, and patients who have polycystic ovarian syndrome often they do have an increased risk of diabetes. So if this patient was polycystic, had PCOS, and had diabetes or was overweight, we could give her metformin and it could help with both. Urofoliotropin is I'm pretty sure that's luteinizing hormone that you give as injections, but we don't need to do that. And wow, okay. Oh, hello, person who joined me. And isotretinoin is a medication used to treat acne, and you do have increased acne if you have polycystic ovarian syndrome. So you could use those other medications, but much more likely, first line treatment, use combined oral contraceptive pill. Cool. Next question. A 65-year-old New Zealand European man who was admitted to the surgical high dependency unit after an emergency repair of his AAA is noted to be passing only small amounts of urine. He has a history of hypertension and type 2 diabetes. So how do we manage this patient? We could organise a renal ultrasound, we could determine optimise fluid status, we could deliver IV antibiotics, or we could organise a unit of cross-matched packed red blood cells. What do we think the answer is? Alright, pause, have a think about it. Answer probably, in this case, is pretty simple. We would just want to optimise his fluid status. So this patient probably has had a acute kidney injury, and we can, as we can do with anything, we can break this down into pre-renal, renal, and post-renal causes of acute kidney injury. And this person has had pre-renal kidney injury because their AAA has meant that they've had very poor perfusion to important organs in their body, including their kidney. And now their kidney has gone on strike for a little bit and they're passing very small amounts of urine. Optimizing fluid status, we are just waiting for the kidney to come back to normal. So you're making sure that their fluid status is okay, making sure that their sodium potassium levels are fine, and waiting for them to turn the corner and for their kidney acute kidney injury to get better. You could organise renal ultrasound, but that probably wouldn't tell us very much. Could deliver, well, you shouldn't deliver IV antibiotics, as they have no reason to get antibiotics. And you could give them red blood cells, but you don't need to. They don't need red blood cells because it's all about fluid status. Red blood cells would be unnecessary. We only give red blood cells to patients if their hemoglobin is less than 70. Cool, so that's just an acute kidney injury question, and it's designed to make you think about the different stages or the different ways we can get an acute kidney injury. So pre-renal, renal, and post-renal. So example of pre-renal is dehydration, hemorrhagic causes, for instance in this example, AAA. A renal cause could maybe be drug-induced acute kidney injury, and a post-renal cause could be urinary tract infection or something that affects the ureters. Alright, next question. A 45-year-old Māori man is referred to you by his GP. He was diagnosed with diabetes 15 years ago, and routine monitoring of his renal function demonstrates a steadily increasing serum creatinine. Renal ultrasound reveals small echogenic kidneys. His blood pressure is 150/92. The normal surface landmarks for the kidneys are associated with which ribs? So this is an actual question from the clinical scenario database and made me laugh, so I thought I'd put it in here. Here's a great example of how you've got your awesome scenario and you're thinking when you're reading it, oh yeah, I know what they're going to talk about, and then the answer's completely left field, but let's go over the answers. So it could be ribs 10 to 12 on the left, 11 to 12 on the right, 11 to 12 on the left, 11 to 12 on the right, 11 to 12 on the left and 12 on the right, rib 12 on the left, 11 to 12 on the right. What do we think the answer is? You guys have to think about it. Cool, well the answer is ribs 11 to 12 on the left and rib 12 on the right, and that's because we have the liver on the right. So the kidney is pushed down a little bit, so it's only associated with rib 12, whereas the kidney on the left is a little bit higher, so it's ribs 11 to 12. Not too much to think about there. Right, you're looking through the notes of a 65-year-old Romanian man who has requested dialysis treatment. His EGFR is listed as 25 mL per minute. So what stage of chronic kidney disease do we think he suffers from? Stage 2, stage 3, stage 4, or stage 5? And the answer is stage 4. If we can think back to our stages of kidney disease with our EGFRs, so stage 1 is a normal or very high GFR, and it's over 90. Stage 2 is a mild chronic kidney disease, and that's 60 to 90. Stage 3 is, well, there's 3A and 3B, but essentially it's 30 to 60. Stage 4 is 15 to 30, and then end stage chronic kidney disease is less than 15 milliliters per minute. Alright, an 8-week-old New Zealand European boy comes to his GP as his mother has noticed he has a lump in the lower part of his tummy on the right. He is subsequently diagnosed with an undescended testis. What is a complication of undescended testes in adults? Is it testicular cancer, delayed puberty, hyperandrogenism, or entrapment syndrome? Have a think about it. What do we think it is? It's probably testicular cancer. When we think about an undescended testis, it's also known as cryptorchidism. Complications are testicular cancer and hypoandrogenism, because that testis isn't going to be working as well. Not hyper. Delayed puberty, not discussed in the literature, although it might happen, but most the complication there that we know for certain is testicular cancer. And entrapment syndrome doesn't exist, it's not a real thing. So next question. We're nearly finished up with the questions. A 24-year-old New Zealand European male presents to the GP clinic with a 2-week history of pain on urination, pain when having sex. He has recently begun a new relationship and he is diagnosed with chlamydia. So this is an epidemiological question. What 2 age groups have the highest prevalence of chlamydia? 20 to 24 and 25 to 29, or 15 to 19, 25 to 29, 25 to 29, 30 to 24, or 15 to 19, 20 to 24. And have a think about it. And what do we think? probably 15 to 19 and 20 to 24. It is a disease most commonly found in young people, and it is a disease of the serially monogamous. And it's important that people who are diagnosed with an STI are treated immediately, and that they go back and talk to previous sexual partners over the past maybe 9 months, I think, or 6 months, and make sure that those people are tested and treated too. Alright, we're getting there. 55-year-old New Zealand European man collapses at work with sudden onset of right-sided weakness. His wife tells you he recently had a short episode where he can't find the right words. He has hypertension that is reasonably well controlled with bendroflumetazide. So what is the mechanism of action of bendroflumetazide? Another excellent question where you have an entire scenario and then the question is not anything like the scenario. So, mechanism of action of this drug: does it inhibit reabsorption of sodium and chloride? Does it block angiotensin converting enzyme? Does it inhibit the actions of aldosterone, or does it block the sodium, potassium and chloride transporter? The answer is that it inhibits reabsorption of sodium chloride ions. That's what thiazides do. Cilazapril is the answer to what B is. Blocks ACE, angiotensin converting enzyme, ACE inhibitors. Spironolactone inhibits the action of aldosterone, and furosemide blocks the NKCC2 cotransporter. So we do learn about these drugs and how they work on the kidney, and could be a very reasonable question to ask in a progress test. And the final question that I have for today: 72-year-old Māori woman presents to a GP with conjunctivitis. She mentions to a GP she has worsening kidney function. What medication does not have potential side effects in the kidneys? So penicillin, ibuprofen, cefuroximine, or paracetamol. Have a think about it. Going through it, it's probably Panadol. So Panadol can cause kidney damage actually, but it causes liver failure first. The other three, penicillin and other beta-lactamase antibiotics, can really damage your liver. Ibuprofen, your kidneys. Ibuprofen is a NSAID, and they are notorious for causing kidney damage. Cefuroxime is another antibiotic that can cause kidney damage, and Panadol does not cause any kidney problems before it causes liver problems in the first place. So people who have worsening kidney function and who would like to have pain relief, Panadol is a good choice, not Nurofen. So that's the end of these questions. There will be, hopefully a recording of this tutorial will be put up, and the slides will be put up too. Tutorial went very fast today because, quite reasonably I think, no one wanted to come into MAPAS house on the Saturday after their PST. I hope that went well for everyone. But there'll be a couple more of these tutorials. Come along, they'll be on Saturdays again at 1. And you'll get a Canvas notification beforehand about it. And I will stay on Zoom chat, I guess, for the next half hour or so if anyone wants to ask questions. Cool. I'm going to mute myself now. Thanks, friends.